Hello, and thank you for joining our webinar today. My name is Paula Blonsky. I'm the president and co-founder of the ARDS Alliance. The ARDS Alliance was formed to help all those affected by ARDS. We are a patient advocacy organization dedicated to our patient community. We have four main focus areas: patient engagement, education, policy advocacy, and health equity. Our mission is to improve the lives of all those affected by ARDS. We do this by promoting and furthering education and scientific opportunities, raise awareness, and ultimately fund research. Today's webinar will talk about ARDS and sepsis, research, including challenges, and you will hear from two survivors about their journeys with ARDS and sepsis. I would like to personally thank our panel for joining today to help us educate on this very important topic. If any of the attendees have questions, please use the chat function below. We will try to get to as many questions as we can at the end. So first, I would like to introduce Dr. Renee Stapleton. Dr. Stapleton is the professor of medicine in the pulmonary medicine department at the University of Vermont Medical Center. Dr. Stapleton will be providing an overview of ARDS and sepsis. Dr. Stapleton.
Thank you so much, Paula. Happy to be here today. So I think my task for the next several minutes is just to provide a fairly broad overview of what sepsis and ARDS are. And I guess I'll start with sepsis as opposed to ARDS, because sepsis is the most common cause of ARDS by far. These two entities, sepsis and ARDS, are really not discussed and mentioned nearly as much as I think they should be in the media that we all see every day. There's always information about cancer and heart disease and heart attacks and dementia, but rarely do you read anything about sepsis or ARDS, despite the fact that both of them are really quite common. So sepsis is really kind of simple. It's documented or suspected infection plus organ failure. So if you have a pneumonia and you need oxygen, you have sepsis because you have some respiratory failure, you need some oxygen. If you have a bad kidney infection and your kidneys aren't functioning well, that also meets the definition of sepsis because it's infection plus kidney failure. There's another kind of step up with the septic definition that's called septic shock, and that just means that you have evidence of your organs not getting enough oxygen, not enough oxygen delivery from the blood. And we usually measure that by something called lactate. That's just a reflection of your organs making too much acid, so to speak. So sepsis is incredibly common. There are thought to be about 50 million cases a year worldwide. And unfortunately, it's still very deadly. It causes about 20% of all deaths globally. So incredibly important problem, something we don't hear about enough at all. Now let me move on. And I guess I should also say that another way to think about sepsis is just an infection that tends to affect other areas in your body. So it kind of spreads throughout your whole system. Let me move on now to ARDS. And the definition of ARDS has sort of changed over time. We first kind of decided what it was going to be in the early 90s when a group of experts met, and that's happened 2 or 3 additional times since then. ARDS is basically a very excessive inflammatory response that a person has to either infection or some type of injury. And the lungs are a really fragile organ, and that excessive inflammatory response injures the lung at the level of both the tiny air sacs that are called alveoli, as well as the tiny capillaries that take oxygen out of your lungs and put them into your blood, and also release carbon dioxide back into the lungs so you can exhale. So the injury of ARDS happens both the tiny air sacs and the tiny vessels. And the way we define it has to do with how much oxygen people are needing, whether or not, how long ago symptoms started, and et cetera. There's a list of criteria that intensive care unit providers use to define it, but basically it's injury of the lung tissue and the vessels. The most common cause of sepsis by far, the most common cause of ARDS by far is sepsis. Sepsis causes about 80% of all the cases of ARDS. ARDS is also pretty common. One of the best studies that was done, which is now about 20 years old, on trying to figure out how common it is, found that we think there are about 200,000 cases in the US per year. I think based on a newer definition, that that incidence is probably a lot higher. It's no longer the case that people need to have a breathing tube in their windpipe and be on mechanical ventilation to be defined as having ARDS. With a new definition that's very recent, you can now have something called high flow oxygen. So we're including people with less severe injury to the lung in the definition, which I think is really important because it matters to define it so we can treat it properly. When ARDS was first sort of discovered or named way back in the 60s and the 70s, the mortality from it was about 60 or 65%. Now it's probably more commonly around 25%, but still incredibly high. I mean, still about 1 in 4 people who have ARDS don't survive to leave the hospital. And despite decades and decades of research, there are really only 2 things that we know of on a large population basis that can help treat ARDS and save lives. And those 2 things are to make sure we're using low breath volumes on a mechanical ventilator, and in more severe cases that we place patients on their stomach in what's called the prone position. A lot of drugs, a lot of other therapies, like dozens and dozens and dozens, have been tried. And on a population basis, there's not a pharmacologic therapy yet that's been found to be helpful, with the exceptions of medicines that were found to be effective during COVID. You know, the lung injury that we saw during the COVID pandemic and are still seeing in those patients is ARDS. It's just a very specific form of ARDS caused by COVID alone. And we know that things like prednisone, steroids, and other immune modulating medicines do help, but in all-comer ARDS, they really don't seem to be effective. So much more investigation is needed. Other things that cause ARDS are massive trauma. So people who are involved in really severe car accidents or other types of injuries can get ARDS. Pancreatitis can cause it. Folks who have an inhalation injury, for example, if they might be in a house fire or some other inhalation exposure. And there's a whole list of a few other things that are more rare. But by far the most common one is sepsis. And I think I'll also add that over the past 10 years or so, a group of researchers at the University of California in San Francisco, led by Carolyn Calfee, has really found that ARDS can now be divided into kind of 2 what we call phenotypes, sort of flavors. One is a hypo-inflammatory type, and these tend to be people who all of their blood parameters, a whole list of blood parameters and like signs and symptoms that we look at are less inflammatory than this hyper-inflammatory cohort. And the hyperinflammatory cohort tends to have worse outcomes than the lower inflammatory group, but that's not necessarily associated with cause. So you can have sepsis as your cause of ARDS, but be in either group. So we're still trying to sorting that out. In the research community, there's so much about ARDS and sepsis that we don't know. But I'm really happy that we're here discussing it and trying to spread the word, because they're both just such important things to discuss and understand. I think I should stop there
Okay,
and maybe leave some time for questions at the end. Is that okay, Paula?
perfect. Perfect. Thank you, Dr. Stapleton. All of that very relevant, and I agree, so much more to learn, right? Okay, so next I want to introduce Rick Bressler. So Rick survived COVID-19 and ARDS in 2021. However, the only way he could survive is to undergo a double lung transplant. Rick is an inspiration to everyone he meets, including me, and brings hope and sometimes humor to an unbelievable story of survival. Rick?
Hello, everybody, and thank you for that very overly kind introduction, Paula. But yeah, so I am one of the people you were actually referring to, Dr. Stapleton. I am one of the very specific COVID-induced ARDS individuals. It was just after the first year of the pandemic, and finally, you know, people could schedule to get the vaccine, and I was scheduled for the vaccine, and it was just when it was coming out. 4 days before my first appointment, I tested positive for COVID, and things went downhill rather quickly from that point. I went in with COVID double lung pneumonia. My lungs collapsed multiple times. Fluid in my chest cavity. I went through a lot during that period of time. We got to a point where the doctors asked us to consider volunteering to be put on the ventilator before it became an emergency. That's how rapid my decline was. And they would rather do the insertion not under like rapid terms, and rather handle it nice and easy so there was no potential damage. And ultimately, my wife and I, we talked for a few moments alone, and I got on the ventilator. And I don't really remember anything after that until after my double lung transplant. However, I can still tell you about a few things. So I was initially put on the ventilator. 3 days after that, I was actually placed on ECMO. For those who don't know what it is, it's extracorporeal membrane oxygenation. And it's essentially a bypass for the lungs and the heart. To help my body, it circulates the body or the blood out of my body, reoxygenates it, puts it back into my system. That was in hopes to give my lungs time to rest and heal. I was placed in the prone position. I have received so many different types of treatments to try and help it. It was pretty incredible. A lot of different medications and therapies involved. Ultimately, though, very quickly, they already started talking the fact that I needed a double lung transplant, or I wasn't going to survive. And where I initially was, they did not do lung transplants, let alone COVID lung transplants, because there are more sensitivities to that than a typical lung transplant. So ultimately, they had to find a metropolitan system to be able to handle my case, and I ended up getting life flighted to Penn Med, which is in Philadelphia, Pennsylvania. And I arrived there, and it was about a week and a half later I got approved. I got placed on the transplant list. I had a very high score. Essentially, I was dying. And within, I think it was within 13, 14 days of me arriving there, my wife got the wonderful call that my life was going to be saved. And fortunately, got a double lung transplant. And it was really, at that point, it was really getting close to if something wasn't going to happen soon, they were considering having that chat with my wife about what to do moving forward. So I'm glad we were able to avoid that conversation. Recovery from a double lung transplant is already difficult in itself. But what added to mine was the fact that I had to be kept still. And it was for 2.5 months, nearly 3 months, that I had no food, no water. It was just feeding tubes. I had to be kept still. I apologize, I can't remember the name of it, but it was on one of those beds that would adjust pressure underneath my body to try and help with pressure sores and ulcers and so on. But I come to, I'm in the intensive care unit, didn't even know I was in Philadelphia. And I woke up and I couldn't move my legs. I'm looking around and I'm like, well, apparently this happened. I saw the staples across my chest and realized, surgery happened. But what I didn't know was 2.5 months went by. And so I got slapped in the face very quickly with a lot of info. And my recovery was a lot of physical therapy, mental health therapies, a lot of different practices. I tried everything to feel better, to get my strength back. And I went through a wonderful program to help me with that. And of course, I still had to do pulmonary therapy after that as an outpatient. So I was essentially away from home for 5.5 months. Not all of it in the hospital, but a majority of it because I otherwise had to stay in that area for the treatments. Recovery and living life post-transplant has been difficult at times. I'm not going to sugarcoat it. It's been a little trying, especially lately for me. But it has, definitely humbled me in many ways where now I really appreciate just being able to go for a walk when I can, because at the moment I'm not able to really do that very well. It's also when you're somebody that's used to having to rely on yourself and can handle things on your own and can multitask. I'm far from that now. That's frustrating, but you have to learn to, I think it's not necessarily for me, it's not necessarily focusing on what I was, but what I can be with my current situation is how I try to think of it. And so that means volunteering when I can, doing webinars like this, working with the ARDS Alliance. I'm very proud to say that I am one of the board members, actually. And I just try my best to, I don't know about an inspiration, but if I can help somebody, I'm all for it. So there are certainly a lot more details about everything that happened along the way. If anybody is curious, wondering why I'm wearing oxygen, sadly, I had a recent, very rough battle with A3 acute rejection, which then blossomed into full-blown chronic rejection. And my lung function has dropped significantly over the last couple of months to the point that I need oxygen now. And as it turns out, everything has progressed enough that I am actually in the process of seeing about potential approval for a second transplant. So the irony here is I'm going through the process again, but this time as somebody that's chronically ill and not somebody as an emergency case. So I'm really getting to experience all sides of it, which I can't say that I really want to do, but here we are. So we're just trying to push back as hard as we can and get through it. Otherwise, thank you for listening. I don't want to go over my time, and enjoy the rest of the webinar, folks. Thank you.
Thanks, Rick. Yes, definitely you and Carol are the reason we're here, right? So next I want to introduce Claudia Orth. Claudia is the Director of Professional Education and Training at the Sepsis Alliance. I'm so grateful for the support and collaboration that the ARDS Alliance and the Sepsis Alliance has. Claudia has over 20 years of experience working as a registered nurse in critical care, clinical quality, patient safety, and sepsis. Claudia will be speaking today about the Sepsis Alliance and how they engage patients in research. Claudia?
Thank you so much, Paula, and thank you, Rick and Carol, for sharing your stories and reminding us why we do the work that we do. I'm honored to be here today to talk about Sepsis Alliance and Sepsis Alliance's free resources. As Paula said, my name is Claudia, and I'm the Director of Professional Education and Training with Sepsis Alliance. For those of you that may not be familiar with Sepsis Alliance was started out of a personal tragedy by our founder, Dr. Carl Flatley, who lost his healthy 23-year-old daughter, Erin, to sepsis after a routine outpatient procedure. At the time, as a practicing endodontist, Dr. Flatley had never heard of sepsis, and in further researching sepsis, quickly identified a national gap and need to educate and provide resources to raise public and healthcare professional awareness. Sepsis Alliance was the nation's first and leading sepsis patient advocacy organization, and everything we do is centered around including the patient voice and lived experiences, such as those as Rick and Carol's. We also pride ourselves on being a trusted partner to patients, healthcare professionals, quality improvement organizations, researchers, government, and industry. Our focus is on infection prevention, which of course is sepsis prevention, sepsis recognition, treatment, life after sepsis, as well as AMR, antimicrobial resistance, health disparities, and innovation and research. Our mission, and really our North Star, is to reduce avoidable suffering from sepsis and save lives and limbs. We always aim to work in partnership with others in the sepsis, infection, and AMR space. Our goal is always to provide the public and healthcare professionals a one-stop shop to meet all their information and learning needs and share all the great work and resources our partners, such as ARDS Alliance, are doing in sepsis, infection, AMR, and health equity space. As we already heard, just like a heart attack or stroke, sepsis is a medical emergency and it is time sensitive. It develops from a life-threatening response to infection, any infection, that damages vital organs and can cause death. So it's not the infection itself, but rather the body's response to the infection, as Dr. Stapleton already told us. Sepsis Alliance developed the time mnemonic, similar again to FAST that you may hear about in the news with stroke. Time stands for temperature, higher or lower than normal, infection, mental status changes, and feeling extremely ill. This can be severe pain, discomfort, shortness of breath. Some survivors say they had a sense of doom and felt the worst they've ever felt. Sepsis is a public and really global health crisis that affects 1.7 million Americans every year. 350,000 adults die every year in the US. That's 250,000 in hospital and another 80,000 in hospice. Sepsis can mimic many other conditions. Why does one person get a cut on their finger or get the flu or COVID and do just fine, and another person develops an infection, sepsis, and even septic shock, and at times loses their limbs or their life? Anyone at any time, regardless of how healthy they are, can develop sepsis, but there are some groups at higher risk than others. Those include the very young, those with chronic conditions and immune compromise, older adults, and the medically underserved. There are many types of infections. Bacterial, viral, fungal, and parasitic infections can all cause sepsis, but bacterial and viral infections are generally the most common ones to cause sepsis. And over 87% of sepsis cases start in the community. The only way sepsis is prevented is by preventing infections. If healthcare organizations are not paying attention to sepsis, they should be. Sepsis is the #1 cost of hospital and skilled nursing care. It causes over 14,000 amputations each year. Sepsis causes long-term, not only physical, but also cognitive effects. Maternal sepsis is the #2 leading cause of death in the United States. Each day, more than 200 children are diagnosed with sepsis, and having an engaged executive sponsor from the C-suite across sectors in healthcare is key to being able to move the needle on some of these statistics. One of the things that makes Sepsis Alliance unique is our patient community. We started as a patient advocacy organization to raise public awareness, and that is still at the heart of what we do. Patients and family voices are one of the most powerful resources, and our members are incredibly active with us, providing stories as we're hearing today, joining us at conferences and in Washington, D.C., advocating and providing education throughout their communities. The good news is we are making some progress. More people are surviving sepsis, and awareness overall is slowly increasing. But for those that do survive, many suffer long-term effects, and some even develop post-sepsis syndrome, similar to post-ICU syndrome or long COVID. Sepsis Alliance offers Faces of Sepsis stories, videos, information guides, coloring pages, visual guides for adults and children with intellectual and developmental disability, caregiver's guide on what to expect when a loved one has sepsis, discharge checklists, etc., etc. We also offer our free virtual support community for not only sepsis survivors, but also caregivers and those who have lost loved ones. Through the support community, we host virtual peer support groups as well as education and resources. And our Sepsis Alliance Connect survivor community actively participates in research opportunities as they are presented to them individually or funneled to them via researchers reaching out to Sepsis Alliance. Sepsis Alliance is also often asked to provide letters of support for research studies, and we're always happy to do that when it aligns with our mission. One of our healthcare professional Sepsis Alliance members recently shared with us that during Sepsis Awareness Month, which is coming up in September, they plan to newly implement handing out sepsis bracelets that have the sepsis.org website listed on them as part of their patient education process on where to find resources and support after patients are discharged. Our survivors and caregivers often tell us that they wish they had known about Sepsis Alliance sooner, that someone had told them they had sepsis and explained sepsis and what that meant for them long term. Now moving into my main area of focus, as I mentioned before, Sepsis Alliance aims to be a one-stop shop to find anything and everything related to sepsis. We provide healthcare professionals a safe and collaborative space to network, ask questions, find and share resources, and take advantage of free continuing education courses, either live or on demand. We are super proud to have over 50,000 healthcare professional members from across the U.S. and across the continuum of care as part of our Sepsis Alliance Institute community, and we are gaining close to 1,000 new members per month. Over the last 2 years, we've worked hard to improve our member experience and to keep a pulse on what the front lines are asking for or in need of. Our resource library is growing steadily. This summer, we've seen over 1,200 documents viewed and downloaded by our members, and many of those documents were shared and uploaded by members within the community. Our peer-to-peer online discussion forum has seen a huge increase in engagement over the last year or two, and participation at times is up to 24 discussions being started per month and over 110 responses from peers to the discussion threads. Sepsis Alliance is accredited by the California Board of Nursing to provide RNCE credits, and we are currently working towards ACCME accreditation in hopes of being accredited by the second half of 2025. We have over 150 on-demand Enduring CE courses, as well as sponsored innovation webinars presented by our industry partners. These are available on a variety of topics, and we are also incredibly fortunate and honored to work with over 275 of the leading subject matter experts in the infection, AMR, equity, and sepsis space. I did also just quickly want to share a few upcoming events that Sepsis Alliance Institute will be hosting in the second part of this year. Our 5th annual Sepsis Alliance Summit is our largest virtual event and is designed to explore an array of sepsis-related topics in healthcare and to include expert presentations from clinician, innovation experts, and influential leaders. We will also be hosting our 5th annual Sepsis Alliance Symposium on healthcare-associated infections to provide an updated clinical knowledge and timely recommendations for infection prevention and treatment and improve outcomes. Pillar 3 is our policy and advocacy pillar, designed to engage change makers in government to provide the legislation and regulatory support for public policy that will improve sepsis awareness and care. Sepsis Alliance started with 1 pillar and quickly grew to 2 pillars and now encompasses 4. Pillar 3 in our Sepsis Alliance Voices is Sepsis Alliance's expansion into the policy and advocacy arena, where our teams are working tirelessly to impact sepsis-related policies, laws, and regulations at the local, state, and national level. Pillar 3 encompasses a grassroots action center, free webinars and resources, and much more. Pillar 4 is our research and innovation pillar. We recognize that research and innovation currently is not meeting the challenge, and that researchers, clinicians, and industry often lack the appropriate diagnostics, therapy, and data. We therefore advocate for and strive to always support, collaborate, and convene industry leaders, researchers, government, and clinicians to support those efforts. And as mentioned earlier, work with our Sepsis Alliance Connect community to educate survivors, caregivers, and family members on how to advocate for patient involvement in research and to personally consider getting more actively involved in research studies. Furthermore, Sepsis Alliance does also conduct survey research around annual sepsis awareness, AMR, and sepsis survivorship. And we encourage all of today's webinar attendees to sign up for our newsletter and become members of our Sepsis Alliance Connect community if you are a survivor, or Sepsis Alliance Institute if you are a healthcare professional. That way you can stay informed of all the work and research that Sepsis Alliance supports or is conducting, while also having the opportunity to participate as appropriately. Sepsis Alliance has 4 main observances. We also support and recognize many other observances, but these are our main 4. The upcoming Sepsis Awareness Month, declared in 2011, is our largest observance and provides an annual opportunity to raise awareness and provide education. We also observe Sepsis Survivor Week every February, Pediatric Sepsis Week in April, and Maternal Sepsis Week in May. One way for everyone to get out and raise awareness during Sepsis Awareness Month is via our Sepsis Superheroes. Since 2017, we've had over 2,700 participants create teams with friends, family members, and colleagues, and then complete a mile, swim, bike, cook, whatever it may be, to raise awareness and raise funds towards sepsis. To learn more, I'd invite everyone to visit our Sepsis Awareness Month page on sepsis.org to access the full Sepsis Awareness Month toolkit with lots of great resources and ideas. And with that, I'll just say thank you so much again for your time and the honor of allowing me to present today. Happy to take any questions, and my email address is here as well for any offline questions later. Thank you, Paula.
Thank you, Claudia.
Thank you.
What a great overview of everything you guys do. So amazing. You have so many great programs. So next I want to introduce Carol Mulkern. Carol survived both ARDS and sepsis in 2016. After her discharge, she was tethered to oxygen for 5.5 years. Then she received her gift of life, a double lung transplant. Her story is one of determination and strength. Carol?
Wow, thank you, thank you. Thank you to everyone. What a great panel you have here, and so much information. And it's still hard for me to believe 8 years later that I am part of this. It still feels surreal. And, you know, as I share my story, you know, parts of it get very sad. But I just want to assure you that, you know, there's a little spoiler alert, and that is that I survived, even though these illnesses tried to take me down. My saga began 8 years ago. My mom had just passed away, and you know, a few weeks later, I started not feeling well. As a single mom, or as a mom in general, you know, we don't get sick, so I really didn't pay too much attention to it. But I did finally go to the doctor, and it turned out I had a UTI. I was placed on medication, and within 5 to 7 days, I still wasn't feeling well. I went back to the doctor, and I was placed on a different regimen of antibiotics. And several days later, I just wasn't feeling right. I didn't want to cause any commotion, but my oldest daughter insisted on taking me to the emergency room. So we went to the local emergency room after I hemmed and hawed that I really didn't need to go. Thank God she brought me. You know, I walked into the emergency room that day, and I often think as those doors closed behind me, I never walked out of that hospital. My whole life changed once those doors closed behind me. I was taken in, my vitals, x-rays, urinalysis, the whole bit was done. And I just kept telling the nurses that I feel like I'm dying. And it turned out that, you know, I did still have a UTI. I think they were going to send me home with another prescription. But I think once I finally said, no, I really feel like I'm dying, and my blood pressure had bottomed out, that's all I remember. I woke up 2 weeks later at a major Boston hospital. It became clear that my health was declining, and I probably wasn't going to make it had I stayed at that particular hospital, because they weren't equipped to deal with the level and urgency of what I was experiencing. I was too sick to be med flighted, so the flight crew had to drive me into Brigham and Women's Hospital in Boston. I was placed into a coma. I had no idea what was going on around me. This is all what's been told to me. But when I was at the first hospital, again, I walked in as a relatively healthy 52-year-old woman, and I ended up leaving in a medically induced coma. And upon arrival at Brigham and Women's, it was determined I had severe ARDS, severe sepsis and ARDS. I spent about a month at Brigham and Women's. It wasn't known if I was going to survive. The family talk did occur. And if I did survive, it was going to be a very long and brutal recovery. So from there, from Brigham and Women's, yeah, I did survive, but I was still very sick. And like my other speaker, Jay, I didn't know that I couldn't walk, talk, or breathe on my own. I suffered from delirium, post-intensive care syndrome. I just wasn't the person that walked into that first hospital. So I was transferred to Spalding Hospital, which is a long-term acute care in Boston, a #1 rated rehab. And it was there that when I arrived, I couldn't even roll my ankles. I could not sit on the edge of the bed. It was like everything I had tried to do, I couldn't do. My body had failed me. And it was one particular day, as I tried to sit on the edge of the bed with like 3 people surrounding me, it was then that I decided, like, my mind, body, and spirit got it. That if I could not sit on the edge of the bed, I was not going to be able to sit in this special wheelchair that they had for me. I would never leave my room. I would never live the life that I used to live. So long story short, I spent about 3.5 months learning to walk, talk, and breathe. And I finally left there to go home. But I thought I was going home to my regular life with a walker and oxygen tanks. There really wasn't a lot of talk about the emotional aspect, about what to expect, about the ramifications of what I had been through. So when I got home, the ladies from my church would come by and they'd take me out for a walk, and I'd walk like 10 feet with my walker and my tanks. I'd be home by 10:30, and my life was like, I couldn't work, I couldn't drive, I couldn't get around my house. What happened was, I wanted to die. The sepsis and ARDS had taken away my joy. And I ended up at Faulkner Hospital in Boston on a psychiatric unit. And I spent 2 weeks there. The reason being is I needed to grieve. I needed to grieve the life that I knew. And, even though it wasn't a perfect life, it's all I knew. But now this new life, I just wasn't prepared for. But with time, slowly but surely, I gained an acceptance. Okay, Carol, you're, 55 years old now. You have a walker and oxygen tanks. And it was either accept it or be miserable. So I chose to accept it. And just as you reach that level of acceptance, all of a sudden, I went from stable to spiraling out of control with regard to with my condition of my lungs. So I was told to visit the lung team, the lung transplant team at Brigham and Women's. And I thought they'd say, you know what, Carol, come back in 3 years and we'll talk. But they didn't. I was told I needed a double lung transplant now. So it was a little more than now. It was 3 months. I was listed, and then I got the call. For me, it was a miracle. Like, I was discharged in 8 days. And what happened was I learned from my sepsis recovery and my ARDS recovery from years ago. So when it came time for my double lung transplant, I was up and ready to go the next day walking. And I was out of there in 8 days. It's been a bumpy road at times. I live in fear of another round of sepsis or any kind of infection. I do still struggle with depression. I still have trouble organizing my thoughts. All these ramifications of sepsis that, you know what, I have to accept this about myself today. I've been given the gift of life. For anyone that's out there and you're struggling or been affected by this disease, for me, I just had to challenge it. I had the dream team where I actually worked there and then was treated there. So that's my story. I could go on for a couple of hours because it's just miraculous. It's due to, I don't know, that higher power out there, and also modern medicine. I just can't say enough about it. So thank you.
Thank you, Carol. It is a story of strength and determination for sure. So I appreciate you sharing that with everybody.
Thank you.
So finally, and certainly not least, I'm going to introduce Dr. Brian Kraft. Dr. Kraft is the Associate Professor of Medicine at Washington School of Medicine in St. Louis. Dr. Kraft will be speaking about ARDS and sepsis and how we are lacking one effective therapy for our patient population. He'll also talk about the challenges of doing research and touch on current research that's being done. Dr. Kraft?
Hi, everyone, and thank you so much for having me. Let me share my screen here. Okay, let me know if you can't see that.
Nope, it's
Um,
perfect.
Thank you again for the invitation. We've heard some truly incredible stories of survival, and I'm privileged to have heard them. These are my disclosures for the last 24 months, mostly in a consulting or advisory board capacity. As Dr. Stapleton already alluded to, the cornerstone of ARDS treatments is lung protective ventilation, low pressures on the ventilator, prone positioning, meaning flipped over on your stomach for those that have moderately severe ARDS. And there's also a third, conservative fluid balance, meaning not overloading patients with fluids, although I'll show you some data showing that's a little bit more complicated than just on face value. And these therapies have been shown in clinical trials really over the last 2 decades, and to be successful, but they're mostly mechanical interventions. There's been very little progress made in the way of biologically mitigating ARDS. It's not for lack of trying, though. We have literally spent billions as a country on trying to develop novel therapies for ARDS that mitigate the biology. These are some of the clinical trials that are shown in red that tested different pharmacologic therapies from 1995 all the way up to the mid 2010s, 2013s, from the ARDS network trials, which was funded by the US government. And unfortunately, none of them really showed any survival or improvement whatsoever in patients with ARDS. The next generation of that was the pedal network that started in 2013 and ended last year, and it was looking mostly at prevention and early treatment of lung injury. And so the thinking was, well, if we can't make a difference with established ARDS, maybe we can improve the outcomes in patients with early lung disease or even try to prevent lung disease. And they've tested a number of different therapies that are shown here. All the studies are named after flowers, rose, violet, clovers, and aster. And unfortunately, these therapies have really not panned out. None of the interventions that they've tested have shown benefit. There's still one study that's being has not been reported yet. That's the aster study, and so we're waiting on the results of that. There was another vitamin C study that also did not really show a benefit, at least in the primary outcome. And the same goes true for sepsis-focused studies. Despite multiple clinical trials looking at different kinds of therapies, it really hasn't moved the needle in terms of improving sepsis outcomes. And there, as of present day, there are no FDA-approved therapies directly for sepsis. Activated protein C has an interesting history. This actually was FDA approved for a number of years and then was withdrawn from the market about 10 years ago after a follow-up study showed that it was not effective, although I'll show you some data about that. The question is, why have all these therapies failed? And I think part of the reason that we're now learning is that our understanding of these syndromes is very rudimentary. We have a very rudimentary ability to describe them, meaning, we look at patients that have a constellation of signs and symptoms that are very nonspecific and can be seen across a host of different biologies. And so, as we evolve from describing patients that have ARDS, and for example, with low oxygen levels, chest X-ray findings like that are shown here, with opacities on both sides of the lungs, and that are on certain ventilator settings. As we spend time and money researching these syndromes, we are beginning to understand that there are subgroups, there are differences. It makes a difference whether the ARDS was due to a medical condition like sepsis or due to trauma, whether it was a direct lung injury from pneumonia or indirect from a UTI. And the biology is really important. So you can have 1,000 different patients with this chest X-ray, but you may have 1,000 different kinds of biology that are actually happening on the molecular and cellular level. And so we're beginning to unravel that host response is important. Genetics are important. The background in which the disease develops is important. What are the comorbidities or diseases of the patient? And part of the work that was alluded to already out of San Francisco has identified that there are different subgroups in ARDS. This is a publication from Dr. Calfee about 10 years ago now that identified, looked at about 30 different clinical variables, some of which were available at the bedside, like vital signs or lab values, some of which are research type labs. And they identified that there are two distinct subgroups of patients with ARDS. The ones that exhibit more inflammation, they called those hyperinflammatory. The ones that exhibited less inflammation, they called those hypoinflammatory. Now, if you ask Dr. Calfee's team, what does hypoinflammatory really mean? They actually don't know. They actually kind of almost regret naming it that, but it's a uncharacterized form of ARDS. But at any rate, these two subgroups have been validated across multiple studies now, including the two that are shown here, as well as others that have since been published, and they've held up across multiple studies. And if you go back and you reanalyze different clinical trials from years past, and you reanalyze the data based on whether the patient would have been characterized as hypo-inflammatory or hyper-inflammatory, they find that the outcomes are actually quite different. And these are studies that were reported as some of them are not having really any effect whatsoever. But when you break it down by phenotype, it actually makes a difference. And so putting somebody on higher ventilator pressures, in this case PEEP, in the higher inflammatory group actually reduced mortality, whereas it was the opposite in the ones that are hypo-inflammatory. In terms of the conservative fluid management, it turns out that reduces mortality if you're in the hypo-inflammatory group. But if you're in the hyper-inflammatory group, you actually want to tend towards a more liberal fluid strategy, giving more fluids. Also, somewhat amazingly, the simvastatin study, simvastatin being a cholesterol medicine that has been long touted as having anti-inflammatory effects, but has not really been shown to be beneficial in ARDS, actually looks like it improves survival in patients with the hyperinflammatory phenotype. So there's a lot that we're now going back and analyzing by phenotype to see what therapies actually make a difference. What about for sepsis? Well, these two phenotypes actually appear to hold true with sepsis as well. These are data shown from the reanalysis of two different trials, the Prowess shock trial, which was the activated protein C study, and the VAST trial, which was looking at vasopressin, which is a medicine that raises blood pressure. And they found that these two different phenotypes are also found in sepsis. And this is perhaps most exciting when they went back and analyzed the activated protein C results. And again, this is a study that was negative. They found that, again, the results depended on which phenotype you were in. If you were in the hypo-inflammatory phenotype, activated protein C appeared to be harmful. But if you were in the hyper-inflammatory phenotype, activated protein C appeared to be beneficial. And so this has created a whole industry now of trying to phenotype patients into different kinds of categories. There's now a study called the APS Consortium, ARDS Pneumonia Sepsis Consortium, that is funded by the NIH, and they have a goal of enrolling 4,000 patients over 5 years to phenotype them every which way they possibly can to learn more about the underlying biology and the trajectory of disease so that they can make a difference at the biological level. There are also other conventional clinical trials that are getting underway. This is one example. funded by the Department of Health and Human Services, a phase 2 ARDS platform trial, looking at these three different drugs to see if they can make a difference in patients with ARDS. And there are over 60 active ARDS clinical trials that I counted on the clinicaltrials.gov website, looking at a whole variety of therapies, some cellular based, some inflammatory based, some metabolism based, and over 100 active sepsis clinical trials, again, looking at a variety of therapies. This is just a few that I've listed here. And so this is an active area of study. And I do want to report some good news. So sometimes trials in ARDS do actually report positive findings. This is one example here where dexamethasone was found to be beneficial in patients not only with COVID on the left, but also with non-COVID ARDS on the right. And this is a therapy that is a steroid similar to prednisone, slightly different biological effects. That reduces mortality and reduces mechanical ventilation in patients. So this is one exciting thing that has emerged over the last several years that I'm seeing used more now in patients. So what does the future state look like? Well, eventually we'll be phenotyping patients in real time at the bedside. In fact, investigators have already developed tools that use just 4 or 5 different clinical metrics that can assign with high accuracy which phenotype, which kind of patient would be in, rather than the 30 different clinical parameters. And clinical trials will eventually enroll and enrich 4 specific phenotypes. So for instance, one clinical trial might want to say, we want to study patients with the hyperinflammatory phenotype and randomize them to this drug or placebo. This might lead to prior therapies that were failed in study to be studied once again and taken off the shelf. But one thing is clear is that there will need to be millions, if not billions, more spent in research investment to identify novel therapies, novel mechanisms of action to truly advance care for both sepsis and ARDS. And with that, I'm happy to answer any questions.
Great. Thank you, Dr. Kraft. There are a couple of questions in the chat. The first one is a shout out to Rick. So you got this, Rick. The second is from Alec. It said, at the doctors, is there any current research regarding reducing progression of patients to ARDS if they are at risk? I am in the UK, final year med student. And for example, with sepsis, we have the sepsis 6, take cultures, lactate and urine, give oxygen, fluids, and antibiotics. Could early proning / optimization of ventilation be beneficial? I see a lot of patients who are already intubated and ventilated, but not on ARDS safe ventilation settings.
I'm happy to take a stab at it, and
Okay.
would love to hear Dr. Stapleton's thoughts also. The first part of that is sepsis is ARDS rather, despite being relatively common, it's also under-recognized, and so it is unfortunately not all that uncommon for patients to be on higher ventilator settings, higher ventilator pressures than you would want, despite having ARDS. In terms of reducing the progression of patients who are at risk for or have mild ARDS, that's what the Pedal Network was trying to focus on, and unfortunately was unable to come up with anything. I'm not aware of early proning having been studied yet, but it is an interesting idea that would be worthy of looking into.
Dr. Kraft, I agree 100%. I think I would probably add a couple of additional comments. So when you're trying to study reducing the development of ARDS in patients at risk, it's actually really hard to study that, because out of all the patients at risk to get ARDS, only a small fraction ends up developing it. So those studies require tens of thousands of patients to prove the outcome, and they're just really expensive and really hard to do. And for interventions like lung protective ventilation, there's no industry or commercial funding available to do those. So you have to rely on national governments to fund those studies. I'm not sure that'll ever get done. I think on the flip side, there's not a lot of evidence that low tidal volume ventilation at 6 cc's per kilo predicted body weight is harmful. So in my view, I think that should be started in people at risk because it's unlikely to cause harm and may help prevent ARDS development. But absolutely, ARDS is way under-recognized. That's been proven worldwide. So it's really important to get the word out and help medical professionals understand the diagnosis so we can do things like use low tidal volume ventilation when it's needed.
Great. Thank you both. Another question, do you know of any studies close to results that could help reduce mortality rates? What stages are some of those trials in?
Yeah, great question. So I quoted trials from all stages, from phase 1 all the way up to phase 3. There are some late phase 3 trials that are finishing up enrollment now, and perhaps we'll have some results next year.
Okay, great. All right, and one last question. Is there any work being done to generate ARDS phenotype specific GWASs? I don't know what that is. I'm wondering if, oh my gosh, somebody else has to read this. Meta-Delinean randomization may have a role of pharmacological lead optimization. Ooh, that was a mouthful.
I
Renee, do you want?
can try to take a stab at that. So what this question is asking, phenotype specific GWAS is genome-wide association. So I think what Alec is asking is if there's any genetic role in development of ARDS and maybe sepsis too. And yes, there probably is, because I think like a couple of people on this panel have mentioned, why does somebody get a cut on their finger and ends up developing sepsis and ARDS? And most of us, it heals up without a problem, right? So there's probably some genetic underpinning there, but I don't think anybody, despite a lot of research, nobody understands what that is or how we might be able to figure out who's most at risk and who's prone and if there are therapies to prevent the development. But I think it's on people's radar. It's just really hard to study.
Great, thank you. And just one last comment, Tina wants to thank Carol for identifying the depression. 100% agree, Tina. Mental health post-ARDS, post-ICU, post-sepsis, you can name all of them, is severely lacking and needs to be talking about more, for sure. So thanks for bringing that up, Carol, for sure. So just to wrap up our time today, if you're a patient or a family member, look for opportunities for research, become a part of the research and become a part of the answer. Reach out to not-for-profits like the ARDS Alliance or the Sepsis Alliance. We have opportunities that we can help you connect with the research. Continue to advocate for yourself and for patients. And don't be silent. We all need to advocate for an effective therapy. And the way to do that is research. So if you're a researcher, please don't stop. We need to find a therapy that will stop the devastation of ARDS and sepsis can cause. We can help you make sure that your work is meaningful. So please always consider including the patient voice. There's nothing more powerful than the patient voice in everything we do. So I would encourage you all. I would like to end with, once again, thanking our speakers and of course our sponsor and partner InflaRx for this webinar. Without all of you, it would not be possible. Please be on the lookout for more webinars in the near future. And if you have a topic you'd like us to tackle, please email me at pblonsky@ardsalliance.org. We'd be happy to look into those as well. But again, thank you all, and I hope you have a great day.